Good morning, everybody, and welcome to this interview with Matthew Bacon and Sunny Deo. If you'd both like to introduce yourselves, tell us a bit about what you do and your interest in surgery.
Well, hi, and thanks for inviting us. And I'm Sunny Deo. I'm an orthopaedic consultant with a specialist interest in knee surgery. I have been a consultant for 24 years and have worked pretty much all of that time at the Great Western Hospital in Swindon. Before that, I trained on the Oxford postgraduate training scheme, and I've also done fellowships in Cape Town and Vancouver. So I've got a sort of relatively broad experience of orthopedics and trauma around the world. I've always maintained a keen interest in clinical research, and as a consultant, I've carried that on not only in larger collaborative studies, but with our own homegrown research and audit projects. And as time has gone on, my focus has really turned towards this issue of trying to define and grade clinical complexity and its relation with both preoperative and postoperative outcomes. My general overview is that there's a slight mismatch between both the perception of joint replacement surgery and its various forms of complexity and the actual reality of the situation. And one of my main aims is to try and address those problems for the benefit of patients. And that's an ongoing project, and I've been lucky enough to join up with Matthew somewhat serendipitously as we were both working with a University of Bath collaboration a few years ago.
So hi, I'm Matthew Bacon. So I'm an academic doctor, not a medical doctor. I came into the health system actually in 2010. So I've had a very different approach to the health system than many that are involved, because actually my background is an airport architect. And I was heavily involved on the planning for Terminal 5. And that meant a lot of simulation work, how we simulated the movement of passengers around the airport and optimised the planning of the airport based upon the simulations. And I was a visiting professor for some years at a university in Manchester. And it was at a visiting professors away day in about 2009, I think it was, that I met the then project director for the 3T's hospital development down in Brighton, which at its time was the largest hospital infrastructure project being funded by the Treasury. And by the October, I was appointed to lead this project for all of the analysis of patient flow and so forth, for its translation into energy reduction and low carbon hospitals. So that's 2010. I won a couple of innovation awards, and that enabled me to take our technology that I developed at the time into Europe. And I spent the next 5 years traveling the highways and byways of Europe after we'd done a lot of the initial work on 3Ts, and found myself doing a lot of analysis in surgical services delivery, working with big surgical centres in Scandinavia and what have you. I had this brainwave about what the problem is in unpredictability of surgical services delivery and what we needed to do about it. I was running a simulation team for all this previous work at the Georgia Tech University in the US. So I went over to the US, met the team, told them what I was planning, and that led to the creation of TCC-Casemix, which we went live with in 2020. And I met Sunny a few years later, as he has described.
You've both got really interesting routes to this issue then. Can you unpick for me a little bit about what you mean when you say complexity in patients and how that affects how you manage surgery and kind of surgical waiting lists.
Complexity in a clinical setting describes the spectrum of patients in terms of the number of additional medical problems that they are carrying at the time of presentation. In general historical terms, and in fact the terms used by the health system at the present time, clinical complexity is based on the number of those other conditions, and we tend to call those comorbidities that a patient has at any given time. There's been lots of historic work over the previous decades looking at how many of these conditions would constitute a clinically complex patient, and so that's relatively well described. And in fact, the coding systems in the UK do take some account of those number of comorbidities that patients have. So the added value of what we're or what I've been describing is based on my clinical observation that actually, if you're a patient with a more severe pattern of arthritis, or you've had previous surgery to that knee that has left you with quite complicated scarring, both in terms of the superficial scars, but also some deep scar tissue in and around the knee, that surgery becomes technically more difficult. And it's really the impact or the combination of local complexity at the site of surgery in combination with multiple comorbidities that I've used the term clinical complexity as the combination or summation of those two things. And our research has demonstrated that those patients who have got complexity both at the site of surgery in combination with systemic complexities have a greater risk of complications, have a higher length of stay, have a higher operative time, and have a greater likelihood of needing more expensive and additional implants at the time of their knee surgery. In terms of individualizing patient care, that clearly has a significant benefit for individual patients because we can give them a much better risk profile and a much better and more accurate assessment of how well the surgery will work for an individual patient, because sometimes there's a mismatch between patient expectation and what actually happens in reality. And my other potential feeling is that a number of non-operative treatments, which may be more appropriate for patients with multiple comorbidities, have proved unsuccessful in larger scale studies because that level of granularity and detail hasn't previously been documented, i.e. all patients with knee arthritis are effectively lumped into one cohort, whereas we would see them as four separate subsets, or four principal subsets. And this is where Matthew's technology and data collection comes in.
Yeah, so Sunny's given a very good overview of the complexity scenarios for the patient. What I would say is the why we created Casemix and what we set out to do with the technology is that we saw that the whole patient pathway through surgery is highly fragmented. You've got all these silos of data. And so what Sunny is explained very well is how you can look from a clinician's perspective at those patient comorbidities and what was happening pre-operatively and something that was happening post-operatively. But in every one of those stages, it's a little island of data, and it may not always be data, it may be documents. And so being able to take a holistic view of that patient journey and the specifics of the patient situation in the surgical pathways now is really difficult. So that was one of the major reasons for recognizing that we need a digital pathway to thread its way through parallel with the patient's journey. So at any point in that journey, we can understand where the patient is and the data relevant to that journey, and the clinicians can do that likewise. But there is another disconnect in the system, and so Sunny talks a lot about patient complexity. What we do need to understand, both from data analytics point of view, surgical effectiveness point of view, surgical safety point of view, is how those complexities manifest themselves in practice, particularly in making a decision about what type of surgery, whether it's a surgical intervention or a non-surgical intervention. And then when the patient has had the surgery, how successful was the surgery? How much better has the patient been made as a consequence of whatever that intervention is? So what we've been able to do is to create algorithms that analyze these comorbidities that Sunny was talking about, and use technology, automation, to place a patient into an algorithm context, which we call a cohort. In technical terms, they're called phenotypes. And then we study the impact in surgery and post-operatively of the interventions on that patient. And we can forecast, based upon the patient complexity, how long a procedure will take. And we can look at all the nuances in surgery from the point of view of the approach, surgical approach that Sunny would take, the type of technology that's used, whether it's robotic technology or instrument guided or 3D, all these different technologies are available, and they will be relevant to specific patient cohorts. And for medical device manufacturers, where surgical safety and product safety is so important, they need to understand nuance-wise how a particular device works with a particular group of patients, a subset, these cohorts, you see. On the one hand, we meet Sunny's needs for predictability of surgery, and so being able to optimize surgical productivity. But on the other hand, we want to ensure patient safety and understand which patient groups benefit most from different types of intervention or non-surgical intervention. And that's why Sunny was saying we need to go back into primary care, because the primary care system needs to understand some of these issues.
So over the past few years, it's been kind of a major headline that the government has really focused on reducing surgical waiting lists. Can you talk to me a bit about how they have gone about that, and how that kind of priority comes into the mix in terms of the work that you're trying to do, and maybe how their approach does or doesn't achieve the same aims?
Yeah, so I mean, there's a long history of the various initiatives to try and get waiting lists down. The additional innovation following developments in the past decade in particular, and a particular clinically led project called Getting It Right First Time, is that there's been an acknowledgement that it may be better to cohort patients who are relatively straightforward and are sometimes called high volume, low complexity patients into specific treatment centres. Those treatment centres or treatment hubs are now up and running up and down the country in various levels of both effectiveness and setup. Certainly from a clinician viewpoint, as someone that does quite a lot of low volume, high complexity work, I personally would say that cohorting straightforward patients into these centres, while it makes sense from a numeric perspective may have potential unseen consequences from the point of view of the, as it were, the hospitals that are left behind. The key question really is one of which patients, as it were, deserve to have their joints replaced as a priority. Is it those with terribly destroyed joints who are medically unwell, or is it the generally fitter and less afflicted patients who fall into that high volume, low complexity category? I mean, there are two issues. So firstly, and I hope that our future research will demonstrate that there are potential mismatches in how good we are at diagnosing straightforward knee arthritis. I don't think we are that good. So people will fall through that, as it were, safety net of being cohorted incorrectly. But also, with any major surgery, there will inevitably be a proportion of patients that will have a complication or a problem. And the sort of double whammy for hospitals that aren't treatment hubs is quite often the treatment hub will have nothing to do with a complication at all. So they will then, we effectively pick up the pieces of dealing with complications, which that obviously takes up both clinical time and potentially additional surgical resource. So you'll potentially find that a hospital that has had all of its straightforward cases taken away from it will also be the complication treatment center for the central high volume, low complexity hub, and that will obviously then have a further negative impact on the number of joint replacements that institution is able to deliver. One of the reasons why I started to collect this data in the manner that I did, almost 2 decades ago, was the fact that I knew I was going to have a higher complication rate, because I was starting at that time, and now pretty well all of my cases are of quite complex cases with multiple comorbidities, and they inevitably do generate a higher level of complications. They have a longer length of stay. My operative, the number of cases I can do on a given list is somewhere between reduced by about 50 to 60% of some of my colleagues. So it looks like I'm a slacker, whereas because the potentially all that the coding people will see is the same operative code, and I'm just doing less of them than some of my colleagues. So that, in a way, that was my very initial driver for actually starting to look at patients in a little bit more detail and to define them by the combinations of local and systemic complexity, and it's obviously evolved over time. The other issue is its potential impact on training of future surgeons. So historically, I've been able to, when the waiting lists were better controlled before COVID, I was able to mix and match my waiting list so that I would have 2 complex cases that I would do, and then I would be able to allocate a little bit more time for a trainee to do a straightforward case. And unfortunately, that really, for me, hasn't happened since COVID. And the issue of those patients being taken away from our waiting lists, again, will have an impact. And whether these treatment hubs are going to be adequately set up for devoting a little bit more time to surgical training, because that then creates a tension between theatre efficiency and surgical training, is something that I'm not sure has been fully appreciated.
I just want to ask you a little bit more specifically about some of the safety issues you've highlighted there, because obviously patient safety learning, that's really our focus, is to shine a light on those issues and potential ways of overcoming them. So there's a few specifics you've highlighted there, particularly around disadvantaging the more complex patients potentially, and also I think, Sunny, in that gap between, you know, if somebody's at one of the treatment centres and then has complications and has to come to you, because we know that transfers of care are a real point, aren't they, for patient safety issues to occur. So maybe if you could just really briefly summarise the safety issues for patients that you're seeing at the moment.
Certainly, from the point of view of higher complexity patients and their presence on waiting lists and the amount of time that they have to wait in as a differential of patients with lower complexity, I think they are being compromised in terms of their overall wait time. The other, if we take a kind of step back and look at that patient subgroup in a little bit more detail, the other issue that Matthew alluded to was the fact that they may have additional, that some of their additional comorbidities may be having a negative impact on their knee condition and vice versa. And the provision of preoperative treatment for that patient cohort is virtually non-existent. So there's a big move towards what we term prehabilitation, and that's a really important thing that I stress to all of my patients. You know, you need to try and get as fit and active as possible in the lead up to your surgery, and you should modify your activities and potentially find alternative exercises that don't aggravate your knee condition. And so if you have a golfer, you say, well, use a buggy, play 9 holes and jump on an exercise bike. If you've got someone who is effectively wheelchair bound because of their arthritis severity and other medical comorbidities, that's a very different scenario and a very different discussion that you're going to have, because that type of patient probably, you know, would and could benefit from one-to-one physiotherapy in a specific gym, maybe with a load reducing treadmill or other devices that are just not readily available at the present time. And again, there are other potential treatments earlier on downstream that patients with multiple comorbidities prior to them having end-stage arthritis may benefit from, such as hyaluronic acid injections and such like, which again may have limited benefit for the whole cohort, but if it has a small positive benefit for someone with multiple comorbidities, that would make it a much more cost-effective treatment. So that's certainly one of the issues, one of the main sort of issues around that. And Matthew's going to chip in.
Yeah, I think this point that Sunny said, what we're looking at is creating personalised packages of care for patients, so that we take their health condition and then identify whether it's a non-surgical or surgical intervention. And we believe a lot of this decision-making should take much earlier in the process back into primary care. And then the question for the patient is, what is the best form of intervention for me at the stage of progression of my knee disease? The problem is we have a lot of too little science knowledge about understanding the benefits of these early stage interventions, and so that's what we're working on together on our research. But the other point is that once the patient then comes into the acute system, the question for the patient, and I'm thinking very much on patient safety issues and other kind of knowledge about that, is, Mr. Deo, if I were to have this intervention, how much better is it going to make me? And to be able to look ahead at the cohorts that have been through this process, all the way post-operative outcomes, what we can now use are our algorithms to capture the data or process the data that we've captured post-operatively, and to then be able to, by placing the patient into their cohort, say, in your cohort, there were X number of patients, and this proportion of them had these quality of life outcomes. These proportion of them had a neuropathic pain reduction of this. This proportion got back to normal life within this time, and all those kind of benefits. So being able to help the patient make better informed decisions is a key component, it seems, in the decision-making process before one actually starts to break their knee apart and put in a new, arthroplasty and so forth. And then when a patient then goes through that process, what we're doing with Sunny is tracking the impact of that implant perioperatively, so we can record in real time any adverse events, any impacts of patient complexity on the soft tissue damage, for example, that's caused by a certain surgical approach, because we're looking to minimize the amount of soft tissue damage perioperatively, so the patient recovers much faster post-operatively. That's the way that we bring all this together, using technology to support the patient decision-making process with Sunny.
Okay, thank you. And can you tell me about a specific insight that maybe you've gained from the work you've been doing in your hospitals, and how that has fed back into some of your processes and made them more streamlined and better for patients? Have you got an example that you can give me?
Yeah, I mean, I think we have introduced, so the clinical complexity grading runs from C0 to C3, with the C3 being the most complex, C0 being straightforward patients, and that grading and the language of that grading has been broadly established within the key departments in orthopaedics, between ourselves as orthopaedic surgeons, our anaesthetic colleagues, our theatre staff, and the ward nurses and physios. So they're aware that, or they're more aware that a given patient is of a higher complexity than average, and that will then act as a set of potential flags to say this patient may need more time in the anaesthetic room, may need more time in the OR, may need slightly funkier implants, and may take longer to leave hospital than a straightforward patient. So that's the language of complexity has been better embedded into our department. There's still a lot of work to be done in that respect, but it's a process that is active and ongoing. I think that overall patients are effectively more appreciative of being told honestly that this is the expectation for their surgical kind of package of care. A proportion of patients, in fact, when I lay out the pros and cons of surgery in the preoperative arena, will actually say, well, okay, I think thanks for letting me know, but I think I'm not going to have my surgery now because I think the risk is too high. And thank you for telling me that. So there, the different ends of the spectrum, having that additional awareness and information is quite important. And then the third sort of group, as it were, are the patients who are quite complex, who we haven't really analyze their post-operative recovery in great detail because it's costly and time consuming, and the pressure of our workload means that we really now only undertake one follow-up appointment for our patients at 6 weeks, really to make sure they haven't had a catastrophic problem. There's a whole bunch of patients that do recover more slowly, that have persistent symptoms after their joint replacement. The more complex patients are more likely to have those symptoms, and obviously that then potentially generates additional cost in primary care, additional cost in patients coming back and being re-referred back into the system with, dear Mr. Deo, can you see this patient with a problematic knee replacement? And in fact, quite a lot of the time, I'll just say, look, I'm really sorry, you're a C3 complex patient, and your recovery, unfortunately, will be slower than average. And actually, you're doing okay. You haven't got a complication. But again, within that cohort of people with persistent symptoms after their joint replacement, a small percentage do have complications. So it's trying to unburden the system as best we can. So it may be that at some point in the future, we say, well, actually, patients who are most complex should have more follow-up and should have more post-operative physio, rather than just delivering a costly package of physio to all patients when you've got your fit and well patient who's back to the gym at 6 weeks. That patient doesn't need post-operative physiotherapy. But the patient who's still in a wheelchair at 3 months, who has been in a wheelchair for 2 years prior to their knee replacement surgery, probably does need physiotherapy. But at the moment, the physiotherapy services will say, we can't deliver that because they're a post-operative, they're way past their post-operative time limit, and we can't then, we're not allowed to give further physiotherapy. So it's that tailoring that really we're aiming towards.
So we have a situation here where there's something about what the health system can afford to deliver as care for the patients, which Sunny said is heavily compromised at the moment. And then there's a view of what should happen. And Sunny's just articulated the different patient cohorts, that one has gone to the gym, doesn't need all that package of physio care. And then you've got the wheelchair bound patient who's now had the new knee and can lead a new life, but they need a lot of ongoing care. So we've taken the approach of developing the technology around post-operative care as well, and being able to again re-stratify the patient in exactly the way that Sunny has outlined. So the technology follows what is the desirable practice, let's put it like that, not what the policy of the ICB is to just doing a 6-week checkup. And interestingly, medical device manufacturers are looking for much more longer-term structured data in order to answer these questions about where the benefits are for different cohorts of patients post-operatively, given different types of intervention. And we can then demonstrate through the evidence of this research, this what we call the routine data acquisition that we're doing, not clinical trials, routinely collecting this data post-operatively, will then help organisations like the National Institute of Care and Clinical Excellence, GPs in primary care, to better nuance the care for their patients, knowing with the data that's available what the benefits are to that patient cohort.
Okay, thank you. So it sounds like a really helpful example of technology being able to enhance human decisions about the best way to care for patients and keep them safe, as well as enhancing productivity. And I think you mentioned at the beginning that it's kind of got applicability beyond orthopaedics. Are there other areas where you can see this sort of approach being really helpful?
So there are a number of different specialties that have to answer exactly the same kind of exam question. And what is the best intervention for the different complexities of patients?
And when I look back and reflect on other patient groupings, it's an absolute given that looking at an individual patient with effectively the lens of, or lenses of clinical complexity gives the clinician a much greater insight into how well a particular intervention is going to work.
So what we're seeing is a big trend towards personalised care, aren't we, Sunny? And being able to create packages of personalised care to patients.
The fantastic sort of element of Matthew's technology is that it does then thread together the entire patient pathway and gives you or gives one an overview of that particular pathway, but it also then contextualizes it and puts it into the context of the whole patient cohort. And I think that's a really novel and potentially hugely useful thing to do.